So, just as a reminder, um, and remember this probably well for your clinical career, but remember this also for test purposes. Tamponade is first a clinical diagnosis. In echo, we confirm tamponade. And it's also one of the few things that are considered a stat echo. There aren't too many stat echoes in the world, but tamponade is one of them. Because the doctors will want to see the fluid and how it's affecting the heart chambers if somebody has been discovered to suspected, I should say, of having tamponade. So with tamponade, we got decreased expansion of the chambers, primarily the all heart chambers, pretty much in clinical tamponade, due to the pressure of the fluid filling the pericardial sac. So what that tends to do is it makes the heart chambers sort of interdependent, and here's what I mean by that. So you get increased venous return to the right side of the heart when you breathe, and the reason for that is the pressure change. Take a breath in. Remember, we interthoracic pressure, interpericardial pressures. So you get increased pressure return to the right side, and this return compromises diastolic filling on the left side. And why is because the right side can expand outward to fill, and therefore the septum that they share between the right and left ventricle bows towards the left side to get as much blood as it can on the right side. That bowing to the left side compresses the left heart, the left ventricle, and not as much blood can get in there during inspiration with this tamponade physiology going on. In fully developed tamponade, I would know this for test purposes, the pressure in all four chambers elevate to the point where they equalize due to the buildup of that fluid. And again, this could be a rapid increase of fluid or a slow increase of fluid that just keeps coming in over a period of time. A short story for you how this can happen. I was a cardiac sonographer at a hospital where we got an order, stat echo, in the ED for tamponade, or suspected tamponade. So obviously this person had checked off the points for Beck's triad. So a new sonographer was with me, and we went down there, and that person wanted to do this test to learn about it. And as on our way down, I was asking him if he had the paperwork on this, and he'd had the paperwork and turned it over, and I looked at it, and just as we entered the ED, I looked at the paperwork, and I'm like, oh my God, I know this person. This is a friend of mine. Let's just call him John. So we go into this all the ruckus in the room he's in. He's in the where, the cardiologist is in there, ED doc. I mean, there's a lot of people in there very concerned about his condition because he's rapidly filling with fluid around the heart here. And the unique thing about John was that he was retired. He's a retired ultrasonographer, general ultrasound. And John also had done echo in his career. So we're scanning him, and John, he's stable at that point, and he's looking up the screen, and he says to me, Steve, he said, that's a lot of fluid. He said, I'm gonna go into tamponade if that continues. And I'm like, well, yeah, I didn't really know what to say to him, but it's not very often that you have a patient who um, knows these things. So, but the cardiologist is looking over our shoulder, and sure enough, the cardiologist had him transported to Maine Med to tap the fluid. And come to find out, after they tapped him, he filled up again. So what happened to John, he was a very active 70-year-old man, extremely active, probably in better condition than most people half his age. And he'd had a pacemaker implanted because of, I think it was bradycardia or something like that. And anyway, he'd had a pacemaker implanted and gone out and not followed directions and exercised too soon. And one of the pacemaker wires, I can't remember which, it just sort of punctured the heart. And so he was, within the heart, blood was draining into the pericardial sac, and so he was in a little bit of trouble there. But just a story. And normal physiology then is subatmospheric, which means that it's negative throughout the cardiac cycle. The pressure is negative throughout the cardiac cycle. Intrapericardial, and the pressure in the sac, can't be greater than intracavity pressure in the heart, right? Otherwise, you won't be able to expand the heart and fill with blood. Something else occurs in the heart. You get this condition called pulsus paradoxus, right? Let's watch this video. Just a short video on.
Hey everyone, welcome to Marvel Medicine. My name is Dr. Chaudhry. This lecture is about cardiac tamponade. This is a huge topic on the USMLE where they can ask you tons of questions. The first thing I want you to do is to visualize it. Imagine the heart, the ventricles, atria, and imagine the way it fills during diastole and contracts during systole, like a balloon. Now imagine the pericardial sac, a circular sac surrounding the heart. Try to get an understanding about the compliance of this sac. It's not very compliant at all. Well, what does that mean? It doesn't expand much. It's not stretchable. If you want to understand compliance better, check out the lecture here. Now that we have those images visualized, imagine a pericardial effusion. Imagine fluid surrounding the heart in this sac. If there's a lot of fluid and that sac isn't very compliant, the sac will fill, right? Now, if that sac is filled, do you think the ventricle has room to expand during diastole when it's filling? Nope. The amount of room it has to expand and fill reduces. So what do you think it does to the end diastolic volume? Goes down. So what happens to stroke volume? Goes down. Do you see how you can expand and extrapolate information? What do you think would happen to your blood pressure? Decrease. The other thing they love testing is the concept that the pressures inside the four chambers equalize. What does this mean? Imagine the heart with fluid around it. Now imagine the ventricles and atria trying to fill up during diastole and expand. Notice that they really can't because the fluid is blocking them. Since that fluid is surrounding the heart all around, each chamber won't be filling differently. It will fill the same around, meaning the diastolic pressures will be the same. This is a huge giveaway. The discussion of tamponade also leads to the discussion of pulsus paradoxus. What you need to know is, in normal conditions, with inspiration, your blood pressure will decrease, but not by much. Pulsus paradoxus is when the blood pressure decreases more than 10 millimeters mercury. Why does this happen? Visualize the heart. Now imagine inspiration. What does that do to intrathoracic pressure? It decreases, right? Negative pressure acts like a suction or vacuum force. With this negative pressure, venous return increases to the right side of the heart. If a patient has tamponade, and now more blood coming back to the right atrium, that means more blood going down to the right ventricle. Now, once all this blood gets there, the ventricle will want to expand, right? Well, on the lateral side, it can't expand because the fluid is blocking it. But look at the septal side. What happens is that the increased preload causes the septum to kind of curve in. When that happens, what do you think happens to the left ventricle's volume? It decreases. So what happens to stroke volume and cardiac output? Decreases. That's why you have the exaggerated drop in blood pressure.
So that's a pretty, I think anyway, simplified yet effective video on how tamponade affects the heart. So again, you have, just to reiterate, you have this respiratory variations when the interthoracic pressure increases during inspiration, decreases during expiration, so on and so forth. So for test purpose, I would try to remember what happens during tamponade and the difference between that and normal respiratory variation. And this is how we analyze that with Doppler. So when you have some sort of tamponade physiology going on, this looks like this is on the right side of the heart here, tricuspid valve, you're going to have, that typically is varying these waves, the inflow waves on the tricuspid valve are typically varying less than 25%. However, with tamponade, they're going to vary more than 25%, and this is certainly going on here. You got this big inspiration, E wave here and a little E wave there, and so on and so forth. And on the mitral side, you'll see variation, but a little bit less. On that side, it's 15% or more. And then you can do the pulmonary outflow here at the pulmonic valve and put your respirometer on there. This is inspiration, expiration, inspiration, expiration, and see how much that varies. Remember, that should vary no more than 10%. And then you do the aortic outflow, and you'll end up with the similar characteristics here. So typically most sonographers, you probably see them doing the inflow respiratory variations. As you can see, this is the EKG, and this is the respirometer. And when it goes up, that's inspiration, comes down to expiration. Now what I do, I prefer to take my respirometer and move it up here, just so the doctor can see the variations at the top of this. And it's not confused with the EKG. And so on and so forth with the outflow Doppler signals too. So with tamponade, increasing pressure in the pericardium or intrapericardial pressure becomes greater than pressure in the heart. Therefore, the cavity collapse of the heart, right, or typically right ventricle, is imminent if this happens, and the heart can't fill during diastole very well. So filling pressure elevation is a compensatory mechanism to maintain cardiac output. And in fully developed tamponade, as we said before, all four chambers, pressure elevates and equalizes. And typically the atria, the low pressure chambers, are affected first. And the RV would be affected next. So the compressive effects of the pressure in the pericardial sac are most prominent during the phase of the cardiac cycle when the pressure of the chamber in question is the lowest. So in ventricles, that would be in early diastole, and the atria, that would be during ventricular systole. This sounds like a test question to me. I would know this for sure. So we're going to pause there, and I'm going to give you a chance to think that over and make video number 3 for you.